Hello, this is Mark Miller. Welcome to the HIFU coding and reimbursement overview for 2024. We've been doing these for a couple years, and they've been very helpful for us communicate HIFU reimbursement coding and ways for facilities like yours that can get involved in this process. So I'm Mark Miller. I'm the Director of Market Access at Sonablate, and I'm excited to be here today. I can see people are already starting to ask questions in the Q&A. It's great. Challenge me in these questions. It's always makes for a better presentation when the questions come in strong throughout the time. So I'll get started, and we're going to take, as I mentioned earlier a minute ago, is that we would start off by taking the first 25 or so minutes to talk about coding and reimbursement, but then we will go questions answers after. So no one be doing we won't have an open comment period at this time. We want to first say that this information is general coding information only. It's not advice for how your facility or you and your physician should code, complete, or submit any particular claim for a payment. It is always the provider's responsibility to determine and submit appropriate codes, charges, modifiers, and bills for the services that are rendered. Payers may have their own coding and reimbursement requirements. Today is information only. We're going to give you what we've learned over the last few years and what I know from readily available public documents. All this information I share today is not private to us. It's available on a lot of the coding systems that many of your facilities use. I have just collected it into one presentation. And then also I'm going to talk a little bit about more of how to get involved, how you can make coverage better, how you can help reimbursement retain its strong case as it is today. The presentation today is set up into three sections: market access overview, number two, HIFU reimbursement landscape of what the codes and payments look like, and then what kind of support Sonablate can give to your facility. You start a new program. What programs can we offer as far as education? Also, what tools are digitized and available to you today? So we'll go through that. Then we'll do question and answers at the end. So I like to start off with this section, this presentation slide always, and any of the presentation I give around training or for facilities, to let you know that market access is much more than coverage, coding, and payment. Many people do this job around the country for different manufacturers of devices, and we are known for maybe what is that code? What's that payment? Is it covered? But what it all starts with, it actually starts way back at the beginning with evidence. The reason we have a Category 1 code at a Level 6 APC for the last few years, strong support for reimbursement, is because the evidence is there for HIFU. The health economics are there for the physician and the facilities, because reimbursement now is covering the costs of doing HIFU procedures. And that was not the case in 2002 or prior to that. And then advocacy. Advocacy to me and to many people is how do key opinion leaders, people who write papers, who want to get involved in studies, specialty societies, and also individual physicians that want to step up and make a difference and provide HIFU for their patients. A lot of times it takes them to go one-on-one and defend the case for HIFU with payers to get it covered. And that in aggregate makes for a better environment in the long run for everyone. So we appreciate those people. And I'll talk a little bit about some of them during this presentation. So the metrics that we look at in our department of market access here at Sonablate are around what is the reimbursement? Does it cover the cost of procedure? What are the particular codes? And are those codes being covered by Medicare? What's the payer coverage as far as private payer, commercials like Aetna, Cigna, United? And then how are the appeals and prior authorizations going? Are there physicians out there that want to get involved in this process, that are willing to step up? And we're doing very well in all four of these categories right now. This was not the case, as I said, in 2002. 2003 and 2004 have been consistent because we've increased 90% reimbursement for HIFU since 2022, because we moved up an entire APC, ambulatory payment classification level. That's very strong, and it's stuck, and it's been consistent for 2 years now. The codes are established, and Medicare now has open access. When I say, I'll talk more about details of these, but we have strong open access, no restriction within Medicare fee-for-service. And private payer commercial coverage is improving significantly on a case-by-case basis. Prior authorizations are encouraged. You really should be doing those. But a lot of those are being approved now, and more so than they were before in 2002. And also, if they're being denied, the appeals are getting approved. And then finally, number 4, advocacy, getting physicians involved, getting them just to do appeals. And if it's appeals denied, then if a prior authorization is denied, doing an appeal. It's really critical in any drug, biologic device in the healthcare world. Without physician support, it's very difficult to have them being used. So let's talk in those 3 sections: coverage, payment, coding, and then payment. Coverage, specifically, as I said, around Medicare fee-for-service. All the MACs, Medicare Administrative Contractors, cover. We say cover. They haven't published a covered policy, but they have silent, which means they do not put any barriers or any restrictions. We know the difference because in 2002, there were 2 restrictive policies. In J6 on the screen, at the left of the screen, National Government Service had a very restrictive policy in the Chicago, Illinois, Wisconsin area. And they had the same policy in JK, which is NGS's New England, New York area region. So there's 12 different regions, but there's 7 different carriers that manage these 12 regions. So in 2 out of the 12, NGS was being very restrictive up until 2022, the end of 22, when we had physicians step up and get involved in this process. 3 of them presented, Dr. Silver, Dr. Fry, Dr. Lomas, all presented in front of Medicare's National Government Service carrier and convinced them that HIFU should not have restrictions. And Medicare agreed. Medicare, within a few weeks of that meeting, retroactively retired the restrictive policy in those 2 regions, which was an amazing turn of events positively for patients, but also a great example of what can be done in any of the commercial payers if physicians want to get involved. And that takes us to that point. Commercial payers, there's no blanket, we approve HIFU right now. Some do explicitly say they cover for salvage therapy, which means that HIFU can be used after a patient had already experienced salvage therapy, which is radiation or radical prostatectomy. We would like to get them earlier. Obviously, we like patients to be treated sooner in the spectrum of care. But in case of some like Cigna, Aetna, Regis, as I say here, and many others, blanket and explicitly say we will cover it for that. But many of them also will cover for focal therapy after active surveillance has been exhausted. So at that point, when the physician decides we want to intervene and the patient agrees, as a team, they want to intervene, a lot of the prior authorizations are being approved now. And that's why we say it's a case-by-case basis. And that's for focal therapy without having to wait for them having to go through that extreme radical procedures. And I'll say that, just highlighting United, we've interacted with United over the last year or so, and they've said they're not interested in writing a policy for HIFU. They would rather look at every case on its merit, case-by-case basis, and many of those are going through now. You have to remember, when a commercial plan, or even Medicare, as you in the example I showed, creates a policy, then they have to manage that. They have to challenge physicians if they send a PA. They have to deny if they don't want to cover for it. By not publishing a policy, United can look at every PA for the merits that it will bring to that particular patient. So it's a really positive situation. So that would be called, as very similar to the Medicare, a silent scenario with a prior authorization. So I show this example in this slide because it's a great way to explain how advocacy and prior authorizations can make a difference, and how there's a misconception in the world of healthcare around prior authorizations. Prior authorizations aren't necessarily the end all to the opportunity for the physician and the patient to use a particular device like HIFU. This was a study that was done and published in 2023, but it was done around 2021 by the Kaiser Family Foundation. And they looked at 35 million prior authorizations, and over 2 million of those 35 were denied or partially denied prior authorizations. And they studied how many of those prior authorizations were appealed, and then how many of those appeals were approved. Well, they found that only 11% of physicians, 11% of those 2 million prior authorization denials were actually appealed. But of the 11%, over 80%, actually 82% of those denied appeals were approved, okay, in some fashion, either once or multiple times, but eventually approved. It is a great example that if physicians are willing to, and let us assist that if we can, get through the prior authorization. If you get a denial, utilize the research that we have in the studies to challenge the commercial payers on that denial, on why they believe that is the case. And many times, and you can see from the statistics, well over 80% of the time, 75, 80% of the time, you have an approval when you thought it was a denial. It's just getting physicians to get involved. So the coding and payment, let's talk about that for a moment. Coding and payment all starts with, where does the CPT code fit within the ambulatory payment classification groups? Every CPT code is assigned to an APC group, and it's all based on complexity of that procedure, even to the point of complexity being how much stress and work and prep is needed to do this procedure with this device. Those are the levels, and then add in, complexity of the disease state, cost of doing this procedure for the OR. All those are factored into which APC group the CPT code is placed. As I mentioned, and I will mention in a moment, we are in level 6 ambulatory payment classification, which is, not surprisingly, better than level 5. In 2002, we were in level 5 and really worked with CMS through advocates to focus them on looking at the true costs and complexity of doing a HIFU procedure. This is a visual of what has occurred over the last 4 or 5 years with HIFU, and a rocky road up until the last 2 years. Since January of 2023, we've been in level 6 and held on to it in January 2024. Level 6 APC, because CMS agrees with us. It's a complex surgery. It should be in the same level as other cryotherapy and others as far as complexity. And the costs are basically the same as that. That's why the reimbursement is similar to some of those procedures and not in the level 5 group. But it takes proper coding and pay and reimbursement claim reporting to maintain that. So that's a part we'll mention and talk about in a few minutes. But let's get to some of the details. I have 3 key slides here. This is facility reimbursement. Then we'll go to this specifically on outpatient hospital. Then we'll go into ambulatory surgery center. And then we're going to end this section on physician reimbursement. And what I like to show, not just HIFU, because that would be pretty boring if we just showed our particular procedure in HIFU. In this case, I want to show you in relationship to other similar procedures in the outpatient hospital department. So you see brachytherapy, it's gone up a little bit over the last year. Cryotherapy and HIFU have the exact same reimbursement because what I had mentioned before, we're in the same ambulatory payment classification level 6, okay? And then robotic prostatectomy. They've gone up a little bit more than everyone else this year, but they took a big hit in 2023. And it comes back to some details about survey that they took in their community. But these two vary subtly every year. The key to maintaining your APC level, as I mentioned, proper coding of HIFU. And we'll talk about that in just a minute. So this is the ambulatory surgery center payment for HIFU and compared to other similar procedures. Brachytherapy, again, cryo, and robotic. You'd probably look at this and say, well, why is HIFU at $4,200 or $4,500, $46, and cryo is a little bit higher? It's like $2,000 more. And the reason is because cryotherapy is considered a device intensive procedure, meaning that the cost of the actual the cost of the device is 30% of the total cost of doing that procedure. And all these calculations are looked at based on that claim. Other people within facilities all over the country do a Medicare procedure, a patient Medicare, send the claim in. All those 400, 500, 600, could be thousands of procedures for HIFU are looked at within the ambulatory payment classification. And then that average cost is looked together for reimbursement rates. But they also say, well, what is the total cost of doing a HIFU compared to the actual cost of that device? And if that ratio is less than 30%, then you do not get the extra payment, which is the device intensive reimbursement rate. That's why they're they're higher than us in the ambulatory surgery center. So for HIFU, primarily our surgeries are being done in the outpatient hospital department, but this is still possible to do it clearly in the ambulatory surgery center. So let's talk about physician reimbursement really quickly, just to be clear. Physician reimbursement is a separate reimbursement amount that goes directly to the physician for their professional time and expertise around the surgery. And those are based on relative value units. Each one of these procedures and any procedure that's done is given an RVU by a committee. They look at the complexity of how to do the procedure. They take in 3 factors, which is malpractice expense, practice expense, which is the second one, and the third, which is the actual work that the physician's doing, as I said, and take those 3, add them up, and that becomes the relative value unit total that you see in the third column. So for HIFU, this year, there's 29.21 RVUs, those 3 components added together. And to get the reimbursement rate, you take the conversion factor multiplied by that RVU. So 29.21 times $32.74 gets you roughly at $956. So we're just comparing this year to last year. And someone may say, hey, why is it gone down 2%? And it comes back to that conversion fact. You can see last year it was $33.88, and this year it's $32.74. That subtle change, because everything else was basically the same. The 3 components of the RVU basically stayed the same. But because the conversion factor, which is set by the government, CMS, and others, determine what that budget can handle for the conversion factor. So every RVU amount in any procedures uses that rate to determine their physician reimbursement. So let's talk about tools for the next couple of minutes, and then we'll get to questions. Please send your questions in at any time. I have a few to start us off in a minute, but I want to talk about tools and support. We're here to support you. A lot of facilities are excited now because they can cover the cost of procedure, but we can offer this great device procedure, HIFU, focal therapy for patients who have been maybe in active, anxious waiting and didn't want to do a radical surgery. And I think a lot of us have family members that have gone through that decision, and they're left with, in a few years ago, with the only option to either have radiation or one of the other invasive surgeries, because HIFU was not being reimbursed enough. But right now, just to emphasize, there's consistency for the last couple of years. We've been in level 6. We're sticking there as long as we continue to do proper education at facilities around proper coding and billing. And that's where these tools come in. Reimbursement guide, coding and billing guide. We have a deep dive on that. This is the blue visual that we see. The middle one is, I'll show you in a bigger form, but we have this in a PDF that we can just send to you. It's been approved through our department. Once again, for educational purposes, it has all the codes. It has CPT 55880. This is prostate cancer, malignant tissue prostate ablation code for HIFU, specific for us. The APC level, if you needed that. The rate for outpatient hospital and ASC. And then at the bottom, it shows what I just mentioned around the physician reimbursement. The middle section here, just to emphasize, is that everything on the charge master needs to roll back up to 55880. So that means itemizing out, what are you paying for the cost of the actual device for HIFU? And this rule applies to any of your procedures, okay? When you have a device, that should be itemized out on your CMS form. And we'll talk about that just briefly. Everyone does it their own way, but it starts with that charge master, making sure that not only is the CPT code loaded properly, but also C1889 in our case, because that designates what that component is that's device cost related. And this is what I was alluding to, is that a clean coding is critical to CMS annual rate setting. If we mess this up as a community for HIFU, if we don't properly account for the costs of doing a HIFU procedure and making sure that all the costs are placed on there, even if you decided C1889 doesn't make sense for us, we don't think that fits, it's your choice. You have to do it the way that your facility and your practice and your physician want to do it. It's your choice. What we're saying is make sure all the costs are on here one way or another, because those costs are being looked at on an annual basis by CMS. As I said, they're looking at the average costs. And if we don't have proper costs accounted for and the costs come in low, there's a risk that we get put back into level 5 reimbursement, level 5 APC, which would put us thousands of dollars less. And that's why this education program around webinars and others and individual meetings is so important. So this, as many of you on the call know much better than I do, is that charge masters drive this. Make sure that these codes are properly placed in your charge master, which feeds, this CMS form and your claim forms. So we're just going to end with a couple slides to say that Sonablate provides prior authorization appeal support. We're here to help you. We can't work on behalf of your patients. We don't have that program, but we can coach and help and assist your physicians on how to properly utilize our studies. We have educational materials that are available to them. We have an example if they're really unknow how to do a letter of medical necessity or appeal example. We have examples for that. We have clinical collection of the different studies that have brought us to this point, 15 years of clinical data around HIFU. We can provide all this to you at any time. And finally, I want to end with saying that it really is a community of individuals that want to use HIFU in these facilities around the country. Improvement has been amazing around reimbursement for HIFU. As I said, we've had consistency for the last couple of years. We're at level 6 APC, strong reimbursement. It's covering the cost of procedures. Patients have access through Medicare, open access, no restrictions whatsoever. So that is a great opportunity to get a program started through Medicare and then work on individual payers within your region that are open to working with you on reimbursement for HIFU. And then the physician's role. Their role is critical to getting guidelines improved. They're not what they need to be, but we're working on that. Medical directors working directly with Aetna, Cigna, other medical directors on understanding HIFU. They as in payers want to listen to physicians. They don't want to hear from us as much as they want to hear from their customers, which are the community of physicians that want to use HIFU as a procedure for prostate cancer. And then finally, appeals and prior authorizations. Please encourage your physicians to do appeals, to put in prior authorizations, and if they're denied, appeal. You can see from the stats I've shown you, over 80% are approved if a physician's willing to go through that process. And I know it's a frustrating series of events, but we're here to help and coach through that also. So thank you for your time. Let's hold on a second. We're going to get some questions, and hopefully I have the answer to them. So we have one of the questions that always comes up is, what is the main driver of commercial payers covering HIFU? Is it the NCCN guidelines or level 1 data or something else? In the big picture, in a very perfect world around market access, it would be purely guidelines. Okay, it would be purely whatever that guidelines, and payers would just blanket follow the guidelines. We know that's not the case, because I know of hundreds of PAs that get approved every year. Over the last few months, I've seen a number of PAs get approved at Blue Shield of California, Aetna, Cigna. They're PAs. They only technically cover maybe for salvage therapy, but they're going through. And if they're not going through, they appeal. And I'm helping and working with our local representatives and getting them approved. So it's not just the NCAA and CCN guidelines. That would be great. And we have to do that. And we are working to improve those. So I can't say it's only that. It really comes down to a physician that says, no, I believe these studies are representative of a safe alternative to the more radical procedures. I'll say this one point is that what we've learned that the interqual criteria mentioned in there, and we've heard this from facilities, that it says that HIFU can be an option for patients who request a less invasive procedure. That's exactly what HIFU is. It says HIFU is an option. So that's why a lot of facilities, not facilities, but payers that use interqual as a use for PAs and appeals are starting to approve, because I think they're starting to realize that if I'm a patient and I go into my physician and we work as a team and decide that I don't want to actively wait any longer and I want to intervene, why am I pushed to have a radical surgery when I have HIFU or one of the others that are focal therapy? But we would like them obviously to use HIFU. We think it's the best. Why can I not choose HIFU? And that's the physicians that we want to get behind, that are willing to do that work. And I know it's frustrating, but it takes special physicians to do that, and we're here to help them in that endeavor. Okay, number 2, is there an opportunity to move up the higher APC over time, more in line with other prostate cancer treatment, which makes it more profitable or more economical and to drive utilization? Yes, it's unlikely. I have to say that it's unlikely that our costs would balloon to the point that we would be moved to level 7. We would have to have 30 or 40% more costs associated with doing a procedure. And if that were the case, I think we would have already seen that HIFU cost about that. It costs roughly $8,000 to do a procedure right now. Or the geographic mean costs are around high 6s, about 7,000. But the reimbursement that CMS said is that they're paying is the 8,777. So that's where we sit. We should not think about much going higher. There's no way to change what the cost of the procedure costs are the procedure costs. What we can control is what we put on the claim. Make sure that the claim has accurate costs. That'll hold on to where we are. That great question. Another question, is reimbursement currently a limiting factor for HIFU becoming the leading primary treatment? No. Reimbursement is not a limiting factor at all any longer. Okay. Reimbursement has gone up 90%. We were having cases, if you can believe it, in 2002 when reimbursement was about $4,500. It's almost $9,000 for every procedure, and it doesn't cost. We don't believe it costs you that. That's something you can work out with our sales team and your facility. But the reimbursement is adequate to cover the cost of procedure and be economical for the facility. So it is not a limiting factor at all at this point. Let me a couple more questions. Thanks for these. This has been very helpful. Also, what does the reimbursement landscape look like? Oh, this is a tough one. I'm not going to be able to cover Europe and Asia. Okay. That would be a question you could send me on email at markmiller@sonablate.com. Most people, I think, on the phone are not focused on that region of the world. I would be glad to figure that out and help that out. We have obviously representatives in those regions, so we can get those answers for you about international. But I'll say this, that we are available in primary major metropolitan sections of the world right now with HIFU. In many cases, especially in London, it's been used at a higher rate than it has been in the United States. Another question, how can a treatment site set their charges such that the resulting values do not limit future rates? You just have to be accurate. I'm not an expert in ChargeMaster, okay? That's what I know. There's some people on the call here that are probably experts in that area. you just have to make sure that the code's properly in there. We also feel that C1889 should be in there for to specifically talk about the device, but they have to be accurate in whatever your, cost to charge ratios, all those type of complexities around hospital billing. And so I can't honestly answer that. Just, you have to be accurate. I'll say this, the other side of it is why I say accurate is because we've noticed, because we purchased last year's claims around Medicare. So we know what the facilities that have done, have conducted Medicare cases reported. And some, if you can believe it, reported $0, $10, some random, very low amount for the cost of the actual device. So we know that there's something off in their reporting. So either those costs have to be put in the other column, which is just around CPT code, or they need to be separated. One way or another, the total cost of the procedure should be representative of what it really costs your facility to do HIFU. Okay, assuming commercial payer coverage policies begin in the next few years, what do you expect the reimbursement would be for those cases? Okay, commercial reimbursement, what we've seen already in the cases that get approved, PAs are approved or appeal is approved. And this is historic. This is not surprising. It happens in most devices, as a commercial payer is typically 15, 20, 25, maybe 30 or 40% more than Medicare rates. And many facilities use Medicare as a foundation for their commercial contracts. I worked at a facility for 3 years, and we were a spine surgery or orthopedic surgery, and we were not, there wasn't a day that didn't go by that we didn't receive a commercial payment that was 30 or 40% easily higher than the Medicare rate. So it should be higher. It should be higher. And if it isn't, I would suggest that your facility should go back and renegotiate your rates for HIFU. So that was all some of the questions I see right in front of me. But one of the other ones I did mention about cryo, a little bit about ambulatory surgery center. Most of our cases are done in an outpatient hospital department. And then, what is the key component? I was going to mention, I think I did already. What's the key component of making sure that we continue to get improved coverage and improved reimbursement? It's through facilities getting involved in the PA process and appeals process, but also are willing to step up if there's some assistance around guidelines. There's committees being established right now at AUA. We're trying to get some motivation there from some of the key players to change the guidelines because they are not representative of the true medical use of HIFU in the community and are not actually accurate. So physicians, we like to believe, are set up into certain groups. Some don't just want to practice medicine. Others want to be key opinion leaders, right? And then others want to do both. They not only want to be a key opinion leader, they want to be an advocate. An advocate is more than just I published. It's someone who's really willing to step up and participate in an interaction with a payer. And that's where we come in to help you through that process. So I'm going to check the questions one more time, and then we might call it a day. I do not think we have any more questions. I'm going to say thank you very much for all of your participation. I know you didn't get a chance to talk, but I see your questions here. We'll have another session in a few hours. If you'd like to jump on that one, you're welcome. And my email is markmiller@sonablate.com. You can always reach us through the website. Also, if you forget that email, markmiller@sonablate.com. Be glad to answer your questions, share information that I talked about today. And we really appreciate your support of HIFU and support of the patients who need it. Thank you.